So hello and welcome everybody to our conference on To Know ALS Better, given by Dr. Geneviève Matte, neurologist. She is the director of the ALS clinic at the CHUM, the Centre Hospitalier de l'Université de Montréal. She is a professor adjoint for the Department of Neurosciences at the University of Montreal. Welcome, Geneviève.
Thank you, Kate. Hi, everyone. So the presentation will be in English. The slides are bilingual, and questions will be at the end, and we can go in whichever language you're at ease, well, French or English for me. So yes, so as an ALS clinic director and ALS physician, I love to present on ALS. This is geared mainly for newer patients. There won't be earth-shattering news today, but hopefully you'll learn all something. Okay, so so this presentation is a pleasure to give. You have to realize that we're physicians, but we're also we have several collaborations. And I have to acknowledge the work we did as a team to develop some of the contents shared today. So as ALS physicians, clinic directors, we meet regularly, like through CALS, which is the Canadian ALS Research Network. I'm one of the co-chairs. But we also meet to develop contents that can be shared with healthcare professionals, but also patients. So here are some of my collaborators on this project. So if we go about what's ALS, so it's a disease that's been described in the 19th century, first by Duchenne, the same guy as the muscular dystrophy. And in the 1860s, the disease was defined further by Professor Charcot. And in France, they call it maladie de Charcot. While in North America, we often use the term Lou Gehrig's disease, which is who was a baseball player who was affected by the disease and passed away at a young age very quickly after the beginning of disease. So overall, it's a progressive disease, heterogeneous as it presents in different ways. And the mean age of onset is between 55 and 65 years old, slightly more men, especially in the younger age group. And it's a relatively rare disease, 1 or 2 cases per 100,000 population. But several patients will live with ALS, about 3,000 in Canada total. So unfortunately, this is an incurable disease, but there are a lot of interventions we can do to make quality of life better, function, and even improve some of the survival. So in terms of life expectancy, unfortunately, it may be only a couple of years after the onset of weakness. But I think there's hope in this regard as well. So if we gave a very simple definition of what's ALS, it's a neurodegenerative disease of the voluntary motor system. So these are those you move consciously. So moving your arms, speaking, walking. And it presents with motor neuron signs. So signs of disease that are the upper motor neuron and the lower motor neuron. So we'll look into this, but that's has to do with how the neurological system is organized, and that's how a neurologist can recognize ALS. The progression is relentless and only over a few months, years, and it's unfortunately still incurable and lethal. What happens is that breathing muscles may become too weak, and patients may lose the ability to swallow, and this may involve complications. If we look at the pathology, what happens at the cell level, at the high level, there are inclusions of TDP43 ubiquitin in the motor neurons, and there are signs of dysfunction. So these are the inclusions when you hear us talk about it. And if you'd like to learn more about this kind of thing, you can register to the CALI, the Canadian ALS Learning Institute. So applications are going on now with ALS Canada. So yeah, is everyone okay? Good. So the classic symptoms of ALS are weakness. So it's a loss of fine motor skills, difficulties buttoning, turning a key, fatigue. So people might notice they can't walk as long as they used to, or they trip. Some patients will present with difficulties in speech and swallowing at first, rarely with breathing difficulties, but it may happen. And the first type of symptom defines the kind of ALS it is. So either bulbar when there are speech and swallowing difficulties, or spinal when it's in a limb. Cramps, muscle spasms, fasciculation, so these are the muscle twitches. These may appear. They may be present early in the disease, but on their own, they're not necessarily significant. So usually when we define the start of ALS, the start of symptoms, we define weakness, which is more noticeable and more specific. There are some non-motor symptoms, so that may accompany the weakness, but on their own, it's different. So there's the involuntary expression of emotions. Some people will call it the pseudobulbar affect. So that is laughing, crying purposefully, but then in an order of magnitude in an exaggerated fashion. And patients cannot stop. So this can be treated. We'll talk about it later. Some patients will have urinary urgencies, incontinence. It's usually rare in ALS. It's not central, but we observe this in some patients. In 5 to 10% of patients, there is clear dementia, so mainly of the frontal type. So this usually doesn't have to do with memory, but mainly with behaviors. So patients may become more apathic, not feeling like doing anything, or will be disinhibited. So will tell people their ways or give their opinions without being asked. Well, okay, some people don't have disease and do that, but it would be a striking change from previous behavior. Yes. So in terms of presentation, how do patients show up in clinic? So about 25% will have bulbar onset, so difficulties with speech, swallowing, and more often in the earlier age group, but a older age group, but it may happen in younger patients as well. 75% of patients will have either a problem in the arm or a leg, so spinal. And there are different presentations that are a bit like ALS, but different. So primary lateral sclerosis, which is a disease where there's mainly spasticity, so upper motor neuron sides. And there's progressive muscular atrophy, which is somewhat the opposite. Yeah, I'll just see if I can get, yeah, you'll see the mouse now. So progressive muscular atrophy is actually the opposite. So all lower motor neuron signs, so only muscle wasting and weakness. There are some variants. Some patients will present with flail arms, so weak arms, but then their legs will function properly. They won't have any problems with speech. There are other variants, such as only 1/2 of the body, just about. So this doesn't help for recognition of the disease, but these phenotypes may carry different life expectancy or complication to expect. So that's why it's useful. So in terms of progression, it depends on where it starts, but usually it's from one site that's affected to another contiguous to another one that's close to it. So if it started in an arm, it's more likely to go in the other arm and afterwards either up to bulbar dysfunction, like speech difficulties, or lower in the legs. So it all depends on patients, and we cannot necessarily tell from when there was only one limb affected which way it's going to go. But it would be very odd to have a left arm and then a right leg. And the rate is variable. So usually patients will have a linear progression. So that is, it will progress always at the same rate, too fast. Rarely will patients observe a plateau, and if it happens, we're glad, but it may be only better coping, better compensation mechanism. So, but the rate is usually the same for a patient. So some will have a quicker disease, others will have a slower one. And as far as reversals are concerned, well, we always question those as perhaps we didn't have the correct initial diagnosis, but there's perhaps 1% of cases that show some improvement over time, but it's very rare. So, as I said earlier, it's progressive. There's nothing curative to offer you for now, but we really think we can make a difference still on function, survival, and quality of life. And it's quite frequent. I'm sorry, my slides are not exactly the same in French and English, but overall, it's relatively prevalent. It's the third most common neurodegenerative disease. And the incidence is quite high, even in older than 65 years old individuals. So something to consider, even in the very elderly population. So how do neurologists approach ALS? So it's a clinical diagnosis. This means it's really your history and the physical examination that will allow us to say it's ALS or it's not. And it's not always obvious very early on, but there are telltale signs to us like painless, progressive weakness. ALS should be considered. Once we meet a patient and think this could be ALS, well, we have to figure out, well, are there alternate diagnoses I should be looking into? Could it be from the neck because the patient's telling me they have a very sore neck? Could it be a polyneuropathy because they say they're numb? So we have to do a few tests. If there are things that don't fit in with ALS, we have to explain them. Is there a second disease happening? And we have to consider what's in favor of the diagnosis to keep it. And as early as we can, well, we'd like to confirm the diagnosis and follow up on clinical progression. So it's fairly simple for a neurologist. It's a bit like taking the metro to a more or less familiar destination. You know where you're starting, you know where you have to go, and you just have to look at how am I going to do this. So I have to take the train towards Angers. Let's say we start from CHUM at Champ-de-Mars. I have to make it to Namur to get to SLA Quebec. So I know I have to take the train like towards Côte-Vertu, or if there's something on the orange line, well, I'll go through the green and then orange. But so basically you follow the signs, you can figure it out. Unfortunately for patients, it's not always the same. Okay, I'm going to go a little further, but it's tough. It's more like taking your car because you can't do otherwise and try to get through Montreal and the Côte d'Orange all over. So for a neurologist, ALS is usually quite obvious. It's a bit like looking at painting. So if you have interest in the Impressionists, you might recognize Les Nymphéas de Monet. So there are hundreds of those. So you've seen one. You see a second one. Well, it looks a bit alike. That could be Monet. And then you see the third one. Yeah, that could still be Monet. It's Impressionist. It's pastel colors. There are nymphs, I'm sorry, can't remember the name, the nénuphars. So it's quite obvious. For neurologists, it's quite clear. It's there are very few diseases that look like ALS. We do some imaging, blood tests, because we're hoping to find something that could explain the clinical picture, but it might. Unfortunately, it's very rare. And the EMG is done to support the diagnosis. We can find the signs of lower motor degeneration, so the nerve degeneration that comes with disease. And it may exclude other causes for the clinical picture. So I've been talking about the upper and the lower motor neuron. So the upper motor neuron comes from the brain to the spinal cord, and it gives a weakness, but the reflexes are brisk. The patient is spastic, so the tone will be increased. And the lower motor neuron signs, that is the neuron from the spinal cord to the nerve, to the muscle, and there'll be weakness with atrophy, fasciculation, so the muscle twitches are from irritated lower motor neurons. And this is really within the basics of ALS, when we within the basics of neurology, signs that allow us to tell what part of the nervous system is diseased. So this is a figure that shows what I was explaining. So the motor neuron comes from the cortex, will cross somewhere at the bottom of the, well, yeah, will cross. So the left brain controls the right side of the body, right side of the brain controls the left side of the body. And the motor neuron will make a connection in the nucleus. So that's in the medulla, where the brainstem for bulbar muscles. And something similar will happen in for leg muscle, for instance. So that's the green one is the upper motor neuron, and the red one is the lower motor neuron, or bulbar motor neuron for the purple one. And that's another illustration of how it crosses for the most part, and the two motor neurons. So as I said, it's a tough road, difficult process journey for the patient. It's a rare disease, so some healthcare professionals might not be aware so much of the disease. It's also a bad news to give. So some healthcare professionals will shy away from telling everything to the patient, and they're afraid to be wrong, truthfully. So they'd rather defer to another professional before telling what they are, if they're sure. And unfortunately for patients, well, there's no confirmatory test aside from meeting an experienced neurologist who's going to have examined them, listen to them, and look at their chart. So we're working on this to make an earlier diagnosis, to make sure it's easier and more certain from the get-go for everyone. Yes. So that's why we're working on biomarkers with initiatives such as our biobank. So biomarkers are a marker of disease that exists in the patient, but it's not necessarily a clinical event. So what we'd like to see in ALS are signs of motor neuron degeneration to see how much it is and does it change in time before the patient becomes weaker, so we can make better clinical trials, include more patients, find the answer quicker. So what's in development, there are some imaging techniques. There's transcranial magnetic stimulation. So it's been shown that the remaining motor neurons before they die are hyperexcitable. So could we use this as a test before there are obvious signs of disease? And there's also through collection of blood or the cerebrospinal fluid through a spinal tap. Well, could we show changes in, could we show molecules that are a signature of neurodegeneration? So that's what's happening now with the neurofilament light chain. So several studies are using this in peripheral blood as well. And the lipid profile may also help us. But these are not used, they're not ready for prime time. So you'll hear about the diagnostic criteria for ALS. They're really a framework we use as researchers and for drug reimbursement purposes with insurances. But clinically, are they important to you? Not so much, in that clinical, the appearance of ALS is quite distinct. So when we tell you you have ALS, it's that we're very certain about it. We wouldn't be telling you this if we thought it was a remote possibility. So this is where we're headed with the Gold Coast criteria, which were elaborated by international ALS experts. It's the Gold Coast of Australia, if you're wondering. That's where the meeting took place. So the Gold Coast criteria is what we're moving towards, and it's really what we do as a neurologist. Do you see signs of upper and lower motor neuron disease in one limb? Is the patient getting weaker? Did you find anything else to explain it? So if it looks like that and you can't explain it otherwise, then it's ALS. The ALS-Coriell criteria are older criteria developed in the late 90s, early 2000s. And basically we collect the info, how many regions of the body are affected by upper and or lower motor neuron signs. And depending on the number of regions, your diagnosis will be possible, probable, or definite. But it's really a category. It doesn't have anything to do with the certainty of your diagnosis. There are some patients who have only a hand involved, and I'm certain this is ALS, while some patients could fit the definite ALS-Coriell, but there are so many things going on with their health that I'm thinking, well, there's a chance this is not really ALS. So overall, if you get your own medical records, don't stress on this. It's not really important. So I've described to you already what's ALS, and we've talked about neurodegeneration, and we see inclusions of abnormal proteins in the cell that show us that the cell is not functioning properly. So are those inclusions a consequence or the reason why things are not working properly? It depends. The jury's out on certain of those questions. If we look deeper into it. So TDP43 is the TAR DNA binding protein. So it's the main protein in it. And it's been shown also in frontotemporal dementia. And this allows to tie in the fact that some patients will have changes in behavior. It changed how we think about the disease. And now we think that ALS is probably on a spectrum of neurodegeneration, with some patients being all motor, all ALS, and some patients being all frontotemporal dementia. And there's somewhat of an overlap in between the two. This molecule's been involved in familial cases. Some genetic mutations have been identified in the gene. And it seems to have several roles within the cell. So it represses transcription. So that's how your DNA will eventually produce proteins. So it may dampen some protein production. It's helpful in the mRNA, so the signal between your gene and the proteins. Apoptosis, so programmed cell death in case everything goes wrong. Well, there's a auto destruction program in your cells. Cellular division, which is not really pertinent in neurons, as they don't divide. So this is a table that shows at a high level of all that can go wrong in the ALS brain, the brain of ALS patient, and might be causative in the disease. I'll just see if the next slide is. So the next slide is not clearer in terms of the design, but overall, there are outside of the cell processes, such as the microglia, which is an inflammatory type of cell. There's some dysfunction of the astrocytes, which are supportive cells. And then in the lower motor neuron, we see also defects in the Schwann cells. So these are the cells that nurture and wrap around the axons, wrap around the motor neurons to help them function and be efficient. Within the cell body, this is where we're looking at the most. We know that there are mitochondrial dysfunctions. So mitochondria how could I say? They're energy manufacturers. So they're the powerhouse of your cell. There are defects in the nuclear transport. So things don't make it back to the nucleus, the center of the cell, are out. There are some defects in the mRNA processing, so the right protein doesn't get produced. There are defects in the axonal transport, so you have to realize that neurons have long projections that get to their target. So if the there's a transportation problem, well, everything falls out. So the axon doesn't make it to the muscle and may degenerate. Some proteins are just abnormal and don't fold properly or don't do their job. And there's the notion of excitotoxicity. So too much glutamate in the tiny environment around the neurons, and that may excite them too much and cause that. So we've observed all those phenomenons, and we're not sure how they produce disease. The causes of ALS, for the most part, is unknown. There are 5 to 10% of cases that are due to that are familial. So that is, there are cases in the family. Most causes are sporadic, however. Most cases are sporadic, so no family history. However, even in patients without a family history, we might find some abnormal genes known to cause ALS in some families. So the most common genes known currently are the C9orf, SOD1, TARBP, so the TDP43, and the FUS genes. And what's peculiar in ALS is that although I'm telling you about TDP-43 and how it's important, and a lot of science talk you'll hear about it will mention it, but there are two forms of disease, SOD1 and FUS, that don't have TDP-43 inclusions, and that's quite important and intriguing as neurologists. So how do you get the same kind of neurodegeneration but without it? And also what's troubling is that most animal models we use are SOD1 based. So they're animals and SOD, so how can it translate into human findings? It's a big question we have. So a lot of models are being developed now with C9 and TDP-43. So C9orf is the most common kind of genetic ALS, and it's an abnormal repeat. So 6 bases in the genetic code that keep repeating themselves. So normally it's under 40, but in ALS patients who have a mutation, they get more than 60, and this appears toxic to neurons. TDP-43 are patients who start off younger, and their evolution is usually longer. SOD1 have a form that's mainly lower motor neuron and rarely demented, but the progression is very variable. It depends on the mutation you get. So a very common mutation in North America is A4B, and the survival is unfortunately very short. FUS is also a mutation we think about in younger patients, and it may look sporadic in that there are no family cases. So I told you ALS is unfortunately incurable and lethal. However, there are lots of things we can do in clinic to help you. So we've developed the Canadian best practices over several years, and they were finally published about 2 years ago. And they're based on expertise and literature, and adapted to the Canadian context. So there are several topics covered in this. How to tell the diagnosis, with drugs patients should be on, the principles of multidisciplinary care, which include respiratory management, nutrition, preventions of DVT, medication, caregivers, and in palliative care. So the cornerstone of care is really the ALS clinic. So a multidisciplinary team that will follow up the patient. It improves survival, and it's been shown to reduce hospitalization. Patients who are followed up in ALS clinics have more adaptation. We've shown they are more likely to have riluzole and probably the other new drugs available, PEG, and non-invasive ventilation, that is the BiPAP. The frequency of visits should be tailored to needs. The base frequency here at CHUM is 3 months. Some patients are not doing well, progress very rapidly, so we see them more often. Other we see less often because their disease progresses slow. And telehealth has actually been shown to be a valid way to follow up on patients. There are caveats, but I think it's an important tool to improve access to care. So once you're told you have ALS, you're told about your options most often. And in terms of drug that may modify the course of disease, there's riluzole. So how does riluzole work? So sorry, I saw there was something in the chat. I'll answer this later. No problem. So what does riluzole do? It decreases the excitotoxicity. So this glutamate access locally that I've shown you. Ideally, we started as soon as possible. It's a very well tolerated drug. However, there are some side effects such as fatigue, nausea, not in everyone. Two serious consequences are on the liver and the white blood cells. So that's why you have regular monitoring. That's very important. In the first studies, we found that there were 3 months longer survival. But these studies were done in the late 90s. The care of ALS patients was not the same as today. For now, if we compare patients on riluzole and patients not on it, we find a median survival advantage of 6 to 9 months. So, which is less than what we'd like to offer, but actually but actually significant in the context of ALS. Edaravone came on the market about 5 years ago, and well, 4 years ago in Canada. So it's an antioxidant, so reduces some of the stresses in the neurons. Compared to a placebo, it showed a slowing of progression in patients who started it within 2 years of onset of weakness. The patients in the study were also at preserved respiratory function. We have some post-marketing data. Some are encouraging, others less. And you have to realize it's an IV treatment that's quite intensive. There are benefits and disadvantages to discuss with your physician. And why do I mention the criteria in patients in whom we've seen a benefit? It's because these are the reimbursement criteria for most insurances and provincial drug programs. So it's an IV treatment. Edaravone is an IV treatment that you take for 10 days out of 14. So over 2 weeks, you'll have 10 infusions, usually Monday to Friday, for explainable reasons. And then you have 2 weeks without treatment. This is a drug regimen that was designed from the previous use of this drug in other diseases. The first cycle is longer, and the infusion, so it's a drip, an IV drip, takes about an hour, but a little more the time to install the catheter and afterwards. So what does it show? So the main analysis was on how much progression there were. So when you come to clinic, ALS clinic, you're usually asked a series of questions which come from a functional scale called the ALS-FRSR. That's what our benchmark for most ALS drugs we study. So the score is out of 48, and an average ALS patient loses about a point a month. So over the 6 months of the study, so half patients had placebo, so they had something infused to them that wasn't edaravone, and the other group got edaravone. So the patients with on edaravone lost 5 points on average, while patients on placebo lost 7.5 points. So that's a difference of 2 points, which is thought to be somewhat significant on the scale, on the evaluation scale, and it was statistically different. So statistically different means we've proven, well, we have a fair chance. So it's fair to say that patients, that the difference we observe has not been observed by chance. We could redo the experiment and we're confident that we'd get the same results. This is another way to show it. So patients were on average similar at the start of study, and after, so there was a 12-week period on which patients did not get any special treatment. And you see as the weeks go that the curves separate, with patients on the edaravone, the green one, have a better score than the placebo patients. In terms of future treatment, there's a new drug approved in Canada as of June, AMX 0035. It's now called Albrioza. So it's commercially available. Some patients might be on the special access program. So it's been shown in the first study to slow disease progression. So patients in the treatment group lost 1.24 points per month, while patients on the placebo lost 1.66. So 0.4 points a month looks very small. It's hard to get an order of magnitude, but the difference at 6 months was 2.32 points. So a fair advantage, similar to what we've seen in the edaravone study. In terms of survival, some data were obtained later on, and we saw that patients on treatment from the start of the study survived about 6 to 7 months longer than patients on placebo. So again, some interesting finding. How does it work? Well, we know the phenylbutyrate helps the stress within the cell, but in a different way than an antioxidant. And the terso helps the mitochondria, so our powerhouses in our neurons. You have to realize that patients were highly selected. That was the purpose of this, was to show an effect. If we take patients who seem to progress faster, we might register something. If we take patients who progress slowly, the drug might benefit them, but it's going to be harder to tease out the effect of the drug. So the patients had the disease starting 18 months prior, and they had a definite disease in LS choreal. So not that they were more certain, only that they had disease at 3 levels of the body already. So it tells you of a rapid progression. They had fairly normal, well, some respiratory decline, but not insufficiency really. And it was a trial with 2 patients treated for 1 on placebo. Yes, and in this study, several patients were on riluzole and several were on edaravone. And the findings have been looked at, and doesn't seem to be, it seems to be an effect of the drug itself, and probably in combination there could be added benefits. So medication carry a lot of hope. However, I told you sometimes access to it is difficult, or might not be tolerated, might not be an option for patients. So there are still lots of things we can do and that are important, that will change your quality of life and your life and your life expectancy. So respiratory care is very important, and it's been a game changer in ALS. So we recommend that every 3 months or 6 months, in case of stability, that we do respiratory tests. So you'll be asked to blow in an appliance, and you might be suggested to start non-invasive ventilation. So this is a BiPAP machine, though, so a mask and a small machine that pushes air in your lungs to rest your diaphragm, so the muscle, the breathing muscle, because the air is going to be pushed in rather than you making an effort to get the air in. So it's mainly useful at night, because lying down, your breathing muscle will work harder, while you're standing, gravity helps you also push down the contents of your abdomen. So it's been shown to improve survival and quality of life, less shortness of breath, better lung expansion, better rest, and survival can be increased by up to 9 months in certain cases. Respiratory care also includes cough assistance. So some patients will have difficulties having an efficient cough. So there are appliances such as a cough assist, some other methods that can be of help. Another game changer is nutrition. So in ALS, your muscles are wasting away because of lack of innervation to the muscles. So you can't allow your body to take energy within your muscles, because this is where, if you're fasting, this is where your body will take the energy first, not so much in your fat reserves, for instance. So the weight has to be followed up, and some nutrition tips can be given, how to enrich what you're eating, making sure you get all of your nutrients. And one of the interventions that may help some patients is having a gastrostomy or gastrojejunostomy. So this is a tube that goes straight from the skin to your stomach to give you a nutrition formula. So it's a bit like Boost, but without the flavor. So the goals of this intervention are to avoid, reduce the risk of aspiration pneumonia. So when patients have difficulties swallowing, well, they may experience some food liquids going in the lungs, which may in fact cause pneumonia. So, and patients might reduce their intake because of this. So the gastrostomy is one way to bypass that. Also, weight loss on its own may be a reason to put a gastrostomy, especially if the patient cannot feed themselves with their hands, or if they have too much fatigue or too much respiratory symptoms. This brings me to the topic of when should it be done? Well, probably early, especially for bulbar patients. Unfortunately, the speech and swallowing difficulties will not get better. So it's probably better to do it while you've not lost too much weight, that your muscles and your body has enough proteins to heal itself after the procedure, but also to make the procedure safe before there's too much breathing issues. If a patient cannot withstand being laid flat or semi-flat, the procedure might not go too well. If we go into too many problems with secretion management, this may make the procedure more traumatic and more difficult. So that's why we're proponents of an earlier intervention, always to discuss with your physician and your goals of care. So our best practices also address symptoms. So treatments are available for several symptoms: sialuria, that's the excess saliva, pain, involuntary expression of emotion, the spasticity, so the muscle stiffness, the cramps, and dysarthria, so difficulty talking. There are ways to deal with it: anxiety, depression, which is not unexpected in the diagnosis, and for cognition symptoms. So in terms of pain, ALS in itself shouldn't cause pain. It's very rare that we find it's only ALS. There's probably something else happening, so we need to address the cause. Fasciculation, so the muscle twitches, it's a very hard to treat symptom, and actually nothing really works. So sometimes just not caring about it is the best route. Options for excess saliva, drooling, or atropine, so drops under the tongue. There were scopolamine patch, so transderm, unfortunately, they're out of back order. So we have other options. Some patients will get Botox. However, it may worsen dysphagia, so this has to be really well thought out. Radiation therapy may help as well, centered on the salivary glands. So we have a great collaboration here at CHUM. Pseudobulbar affect, the involuntary expression of emotion, can be treated with antidepressants, and there's also the dextromethorphan quinidine combination that you can talk about with your physician. For spasticity, well, a lot of management goes through exercise, so stretching may help. Baclofen, tizanidine, so muscle relaxants overall. There are some evidence in other diseases that cannabis may help. There again, talk to your physician. Cramp management is also somewhat behavioral, so having a good stretching routine, maintaining a good hydration. Tonic water helps patients. I'm not talking about gin, just talking about the tonic. Gabapentin, baclofen may help. There are other big drugs that can be used, especially in the context of ALS, but they have serious side effects that you should discuss with your physician. So for the speech difficulties, things can be done, unfortunately not give you back a voice, but with the speech therapists, we can apply for assistive devices or apps that may supplement communication. Exercise is recommended within your limits, so moderate intensity, stretching, passive movements if you can't move on your own to avoid, if you can't move on your own to avoid the contractures. If you like to exercise, good for you, keep doing it. But if it makes you too tired to carry on your normal daily activities, it's too much. If you hurt yourself, it's too much. If the next day you're not well, it was too much. So just pace yourself. In terms of cognition, there are no drugs that may help, but some behavioral issues can be managed by the neurologist and or help of other healthcare professionals. And it's important to address the caregivers, les aidants naturels, les proches aidants. There are lots of resources for them, such as through SLA Québec, par exemple. For instance, so they can be referred to other resources here, but there are conferences specifically for caregivers. So how those guidelines play out at CHUM? So we have a multidisciplinary clinic, and for at least 20 years now. So our clinical nurse is Sophie Villemer. We have 2 research nurses currently, Mrs. Gravel and Robert. And we also have a speech language therapist, Carl Larocque. And we're also helped by a psychologist, Mrs. Dombeck, and spiritual care, Mrs. Bourque. We're 3 neurologists currently at the clinic who see the patients. We offer telehealth. So this was our project in the late 2019. We got all our papers in order mid-February, and well, the pandemic started. So instead of being a pilot project or offered to selected patients, it came everyone. So currently our offer is usually for patients living away from CHUM or who have major mobility issues or different circumstances that don't allow them to come in. We favorize teams, software with video. Teams is the one authorized by the Ministry of Health currently in Quebec. And we try to have 1 out of 2 visit in person still, because some assessments in speech therapy cannot be done at a distance. Some respiratory tests are hard to organize outside of our hospital. Multiple professionals can be involved through these visits. Our psychologist usually meets once in person, and then lots of visits are done through telehealth. And even some of our research projects include telehealth assessments. So this may help some patients who thought, well, they couldn't participate in a clinical trial, reconsider their decision. So in terms of clinical trials, well, they're part of care, if you may say, in that since we don't have anything curative to offer you, well, these are other options you can add to your standard of care. So one of the studies that's recruiting right now is the reldesemtiv trial, a drug that we know of from previous clinical trials, usually well tolerated. And we're trying to see if it may slow the progress of ALS. So here are the inclusion criteria. Usually patients who have had symptoms for less than 24 months, who have some impairments. Riluzole, edaravone are permitted, but also Albrioza. So the protocol has been rewritten since this slide was made. We have an oral edaravone trial. So you remember I explained that edaravone is currently IV. There's an application at Health Canada for an oral form that will make everyone's lives easier. So now that the barrier of the IV infusion is out, the question is, well, could we give it every day to patients? Would it be safe? And would it be better? Do we slow ALS even further? So that's the question we're addressing with this clinical trial. It's for patients who's never had edaravone by IV. So this may be of interest to some of you. We also have a phase 1 unit at Centre de Recherche du CHUM. So phase 1 research are new molecules that sometimes are first in humans. So this is an initiative that was started here for neurological diseases and oncology. The projects recruiting right now are ANX, which addresses inflammatory mechanisms in ALS. So those projects in phase 1 are usually open to more patients as they're very early. So efficacy is not as much an endpoint than safety. So this may be interesting if your disease has progressed for longer than 2 years. We're also doing research that's not interventional, and that's one way most of you can contribute. So through a biobank, so we're collecting samples from patients to learn about ALS. And some patients that may choose to give their brain or spinal cord. So this is an initiative we have at CHUM. There are some others within the province if you're interested. We also try to address the causes of ALS as researchers. So we have a project on copper exposure. So we're measuring copper in patients' blood. We also are looking for volunteers, either from the same household or not. So these are things we can do. So here are some of the coordinates for collaborators. So Mrs. Amiel at Unité d'Innovation Thérapeutique, the phase 1 unit. and also Mrs. Robert for the other projects. And that's it.
Well, thank you very much, Geneviève. That was very, very interesting. I learned a few things actually this morning, so I love that. It is time, people, for questions and comments. So I suggest if you raise your hand if you have a question, open your camera, your microphone, so that we can see you. You can also use the chat in order to send your questions. Donc, c'est le temps pour les commentaires ou les questions. Si vous aimeriez poser une question à Dr. Matte, s'il vous plaît, ouvre la caméra et le microphone. Vous pouvez aussi clavarder vos questions dans la partie discussion. Donc, j'attends les débuts de ça. Est-ce que quelqu'un a une question tout de suite? I do have one question, Geneviève, and I just want to confirm that from your presentation, I understood that people can take the 3 drugs that are currently available for ALS. They can take them all together because they're targeting different things. Is that correct?
Okay. Yes, that's our current understanding. So there was first riluzole, and then came along edaravone, but edaravone in ALS was tried in patients who took riluzole. So 90% of patients in the edaravone trial were exposed to riluzole. For the Amylyx clinical trial, well, it's a trial that was done in the US. So over there, their access to edaravone is, I think, even less than here. And also the drug became available while the clinical trial was ongoing. So that's why you don't see as many patients on it, but it's always thought of as additive treatments for now, as they have different mechanism, as you said. There are some more of a questions for a pharmacist, like, can you take the riluzole exactly at the same time as the Amylyx and the Albrioza? Just check this with your pharmacist. But yes, the treatments can be taken all at once, in the same patient at the same period.
Perfect. Thank you very much. Is anybody have a question at this point for Dr. Matte or a comment? Yes, Madame Blais.
Yes, can I speak in French? Yes.
Yes, please.
Yes. Donc, en fait, j'avais une question par rapport à l'édaravone. Je voulais savoir si ce médicament-là, bon, c'est des traitements IV, mais est-ce que le médicament est assez stable pour pouvoir être donné à la maison? Disons que, je ne sais pas, la patiente a des infirmières dans sa famille puis ça souhaite avoir le médicament à la maison. Est-ce que le pose cathéter peut se faire à l'hôpital puis le traitement peut se faire à la maison par la suite ou le patient doit absolument être à l'hôpital pour le faire?
Non, c'est en fait, c'est en dehors de l'hôpital, là, pour la raison que au Québec, la loi sur les établissements de santé ne permet pas de donner dans un hôpital un médicament pour lequel le patient a payé. OK? Donc, le payeur, c'est l'assurance, dans le fond, l'immense majorité du temps. Donc, le programme, la prescription du médicament par un médecin, ça inclut le support, le programme de support patient de la compagnie. Donc, ils ont leurs infirmières, infirmiers privés là, qui vont venir chez le patient ou le patient va aller en clinique d'infusion. Donc, on voit ça là, dans beaucoup de médicaments spéciaux, là. Donc, le patient, dans le fond, les premières infusions souvent vont être en clinique, au cas qu'il y ait des allergies. Mais on a eu quelques cas initiés à la maison. Il y avait ce qu'il fallait pour réagir. Là, puis, Dieu merci, ça s'est bien passé. Ça se passe toujours bien. Là, mais le cathéter est installé par l'infirmière du programme de support patient. On a des patients qui ont des contacts, disons, minimaux avec l'infirmier et infirmière. Donc, le cathéter est installé au début du 5 jours, le lundi, par exemple. Puis, ils ont ensuite un système de tubulure là, qui est très facile à utiliser puis qui permet un usage autonome. Là. La stabilité dans La stabilité du produit Radicava est quand même pas mal bonne. Là. Il y a des précautions, là, température puis noirceur, parce que ça peut se dégrader à la lumière. Mais le produit dans le sac reconstitué est stable. Avant, quand les gens importaient le médicament du Japon ou des gens qui ont un usage, disons, une importation personnelle là, pour toutes sortes de raisons, souvent vont plutôt faire importer les petites fioles. Puis là, bon, il y a des enjeux de reconstitution puis de stabilité à ce moment-là. Mais en moyenne, c'est plus tellement un enjeu.
Je comprends. Merci beaucoup.
Is there anybody else that has a question or a comment for Dr. Matt? Est-ce qu'il y a autre personne qui a une question?
Ouais. Ben, moi, j'ai reçu un message, je me rends compte que c'est un message direct. Là. Tu peux pas le voir, Kate, mais
OK.
c'est correct s'il y a d'autres questions. Donc, c'est ça. Donc, Madame Thériault, là, qui se demande, est-ce que c'est possible d'avoir une SLA et Alzheimer précoce en même temps? Ben, en fait, Mme Thériault, c'est correct que je réponde ou je vais donner des choses plus vagues, là, parce que je ne sais pas si c'était une question juste pour moi ou je peux en parler à tout le monde. Je peux en parler à tout le monde, OK, j'entends oui. Bon. Donc, c'est ça. C'est sûr que la neurodégénération, on peut avoir 2 maladies neurodégénératives en même temps. C'est rare, on n'est pas chanceux, mais ça peut arriver. Donc, déjà un patient qu'on a vu, disons, nous, c'était très clair au moment où on l'a rencontré que c'était de la SLA, mais le premier neurologue avait appelé ça du Parkinson, puis qu'on se demandait, mais comment ça se peut? Voyons, ça fait pas de sens. Et puis finalement, à l'autopsie, ben, le patient, en effet, avait les 2 maladies en même temps. Donc, je reste bien humble avec ça, là. C'est pas impossible. Mais dans le fond, l'Alzheimer, bon, il y a surtout de l'amyloïde. Puis il n'y a pas vraiment de symptômes moteurs. Hein. Les patients peuvent marcher, les patients atteints d'Alzheimer peuvent marcher longtemps dans le corridor, puis être capables de parler, puis reconnaître leurs proches, mais ils vont errer sur l'étage de neurologie. Alors que la SLA, ben, cruellement, pour la plupart, on reste bien conscient de tout ce qui se passe, puis on faiblit. Donc, ça pourrait arriver qu'on ait les 2 à ce moment-là. Je pense que ça vaut la peine de voir un neurologue spécialisé en SLA et un neurologue spécialisé peut-être en Alzheimer, surtout si c'est une forme précoce.
Il y a une autre question de elle. Elle a dit, mais alors pourquoi un SLA probable?
Ben là, c'est ça. Donc, il y a dire SLA probable comme une SLA probable selon les critères d'LS corial, donc avec des signes du motoneurone supérieur et inférieur sur 2 niveaux. Ou alors dire probablement la SLA. Donc, dire que les déficits moteurs sont probablement en lien avec la SLA. C'est pas simple, madame, je pense. Je pense qu'il faudrait avoir peut-être un peu plus d'avis là, où votre neurologue peut nous faire signe.
Merci, Geneviève. Est-ce qu'il y a une autre question? Est-ce qu'il y a un autre commentaire à partager avec Dr. Matt? Is there any other questions or comments to share with Dr. Matt? It would appear that we have answered everything that people had questions about Geneviève. I would like to thank everybody for their presence today. Just a sec, je fais comment pour vous faire signe, docteur? I'm assuming that she means to have an appointment
Oui,
with Dr.
attendez
Matt.
une minute, je vais juste remettre
The slide with
the slide ici. Là.
the last one, almost.
Yeah, well, actually, the first one is
You've got all
we
your
can
contact
triage
info.
from there. Like
That's it.
so, 514-890-8000 And that's our the extension for the clinic.
254.
2434.
Perfect. Très intéressant de la part de. Sorry, I just saw something. Thank you very much for your comment from the ergotherapeut. And last comment by Madame Thériault. Okay, super. Wow, gros merci. Thank you. So if there's no more questions at this moment or comments, I'm not going to keep everybody. I would like to thank you all for your participation today. We can now end the registration of this. Thank you.